Okay, my guest today is Dr. Sonja Reichert. She's a primary care physician, associate professor and clinical researcher in the Department of Family Medicine at Schulich School of Medicine and Dentistry. That's at Western. She primarily works in the St. Joseph's Primary Care Diabetes Support Program, where she has a focused practice in diabetes, and as well as the St. Joseph's Family Medical Clinic in general family practice. Dr. Reichert is currently the Dr. Brian W. Gilbert Research Chair at Western University in primary care research with a focus on diabetes, multimorbidity, and the integration of exercise as medicine into patients' lives. I like that. And I believe you're also ABOM certified. So that's the American Board of Obesity Medicine.
As of like 3 days ago, I just
Oh,
found
wow.
out.
Okay. Well, congratulations.
I
Hot
passed
off
the
the press
exam.
news. Yeah.
Thank
And
you.
you've published several peer-reviewed papers and have been a recent contributor to the Diabetes Canada Clinical Practice Guidelines, which is definitely something that I want to touch on during this conversation. So thank you for joining me.
Well, thank you, Dr. Appleton, for having me. To prepare, I was listening to one of your podcasts
Uh-oh.
last night, and of course, it was the one with Dr. Hegley. So I have very big shoes to follow after his podcast. I loved that episode and learned quite a bit from it. So just very excited to be here today and to have a good talk today.
Yeah, Rob is great, and he's such a good communicator. He's really good at breaking complex topics down into topics that everyone can understand. So,
Well, I
yeah,
love the Smarties and M&M analogies. You know, working in diabetes, that really resonated with me, that analogy.
right.
So
Yeah.
I'm gonna keep that one and I might have to copy it when I talk to my patients.
Oh, we ruthlessly steal ideas here for sure.
Yeah.
So I'm just curious in your practice, why did you choose to focus in diabetes? Obviously, family medicine is a huge, broad area where you see people through the entire spectrum of their lives. So why did you decide to do the extra training and really niche down your practice into that?
Yeah, it's an interesting path in that I have always been interested in both pharmacological, so traditional medicines, surgeries, traditional pharmacological treatments, and non-pharmacological treatments to battle chronic disease. And diabetes sort of fit that niche as well. I really appreciate being able to help really sick people. So, unfortunately, if diabetes is not cared for well, people can have a number of complications, including blindness, kidney failure, heart disease. So, I really enjoy looking at the whole person, seeing what we need to help and fix, but also what we can prevent and how we can prevent further damage using both pharmacological and non-pharmacological treatments.
Okay. And I guess in a practice like you have at St. Joe's, you have hopefully a ton of support there. So you've got, extra people around that can put the plans into motion. Is that fair to say?
Oh, absolutely. Diabetes is definitely a team sport. I'm so lucky to work with really world-renowned other primary care physicians within the cardiometabolic and diabetes space, but also nurse practitioners. We have a large population of patients that are orphaned or have no family physicians. And oftentimes they're not able to see the endocrinologists or specialists. So we set them up with our nurse practitioners to sort of balance their other medical needs until we're able to match them to a primary care provider. But we also have dietitians who are certified diabetes educators, nurses. We have nurses who are specialized in foot and wound management, as we also care for a large population with that comorbidity. And then we have a social support worker because unfortunately, diabetes can be very expensive and impact people socially if they're off work or need to go on disability. So we really all work together. And the neat thing about our practice is we've done things a little differently than the traditional setup, in that a patient will typically have an hour with us and work with the allied healthcare professional that they need the most as sort of the first contact. And then I see them concurrently during that hour, and I'm able to make any referrals, change their medicine, as opposed to a more asynchronous model that's often typically out there where they sort of see their dietitian on one day and maybe their doctor on another day. So we've set things up a little bit differently. And and diabetes is a real condition of primary care, in that 80 to 90% of patients with diabetes are cared for by their family practitioner, and we reserve type 1 and more complicated cases for our specialty colleagues who we work very closely with. But we're really proud to be, sort of a resource, but also a mentorship and educators for other primary care docs to figure out this landscape of diabetes, and ultimately build capacity so that when we discharge them, they're able to continue the care we've provided.
Yeah, that's awesome. And I mean, the multidisciplinary nature of diabetes care, and for that matter, obesity care and chronic kidney disease and everything else that comes along with it, is just so crucial. And that's one of the struggles that we have in the hospital setting where I do my clinic, is just getting those additional resources, because we always have the feeling we could be doing better for patients if we just had the time and the right people to do the work. So we've clearly got a long way to go in the system.
Mm.
So the thing that sparked this conversation was I just caught in my news feeds that you are in the process of planning a study called LIBERATE, and it currently looking for patients or recruiting for patients, if I'm not mistaken.
Yes, yes. So LIBERATE is an acronym for the Libre-enabled reduction of A1C through effective eating and exercise.
And somehow
And
you get liberate out of that. That makes you sure.
that's right. If
Yeah.
you put the alphabet soup together, you do get the word liberate. But we really chose a word that's empowering and positive, and to reflect the kind of research we're looking to do, where we're looking to recruit 92 patients from London and surrounding area and provide them with really game-changing technology in how they're able to monitor their blood sugars. But then we're taking that monitoring and all this data of this new technology we have, and also packaging it together with coaching or counseling so that they can make sense of their data, learn from it, so put their information into action, and then have the action reinforce behavior change, all with a food and exercise perspective.
So kind of walk me. So we've done a couple of journal club episodes on the podcast. So people have heard me talk about the kind of PICO framework. So the population and the intervention and comparison, et cetera. So who is in this study? Who are you looking for?
So the population we're looking to work with are patients with type 2 diabetes. And, for the most part, in what I'll be saying over the next little bit in this podcast is mostly referred to type 2. If it's type 1, I'll specifically mention it. But we're looking for patients with type 2 diabetes, 18 years or older, who have never used this Libre technology. So they're Libre naive. They have access to a smartphone because the technology that sits in the arm and measures the glucose is actually picked up by a smartphone, and also access to the internet. So those are the main criteria. And then the final one is for patients with an A1C above 8%. So they have some need for improvement.
Okay. And how was the A1C threshold decided? Like why was that the number?
Yeah, so if you get into research methodology, we were looking to have the primary outcome as a change in A1C down to target of 7%. So we crunched the numbers, and in order to not make the sample size too large, if we have a lower A1C threshold, we need a larger sample size, and vice versa. But we also didn't want to exclude people who had, sort of intermediately uncontrolled diabetes. So that's how we ended up with 8% or higher as an eligible threshold.
Gotcha. And of course, as with anything, you have to select the population to give you the best chance of determining an outcome that's actually statistically significant. But that's not to say that the results wouldn't be generalizable to people with an A1C of 7.4, or something that's a little more closer to being quote unquote controlled.
Absolutely. And, this is a research study, and so there are certain parameters like that. But I really see this work as the ideal will be that we can, we're hoping to package this Liberate program and disperse it across Canada and really have people understand and have access to this technology that, like I said, is a total game changer in how diabetes is monitored and treated.
And so you're referring to, is it the Freestyle Libra specifically? Okay,
Yes.
so this is, so it's a continuous glucose monitor, and I think many people will be familiar with that term now. I would think if you're listening to something like this, probably people are aware of it. Right now, I think the status in for funding in Ontario is you have to have diabetes treated with insulin in order to have it publicly reimbursed. But otherwise, I guess maybe some private insurers would pick up the cost for people with type 2 diabetes. But anybody with pre-diabetes, or anybody who's just interested in, if they're at risk and want to track whether or not they have significant glucose excursions from certain foods, you're going to have to pay for that out of pocket.
Yeah, you got it. Historically, so if we kind of go back and think historically, what we had for the longest time were capillary glucose monitors that we're all familiar with, that involve the patient having to do an often quite painful finger prick. And so that technology really limited us with understanding what was happening day to day in a patient's diabetes life. So of course we have the 3-month average, the A1C, which gives us overall control, but the day-to-day data was still missing, and is really important in terms of dosing medicine, in terms of understanding how food is reacting in someone's body, the effect of exercise, if it's helping to lower blood sugars or not. So people at most, measured their glucose 3, maybe 4 times a day if they were really diligent. But I mean, that it was just laborsome and hard, and you're missing all this data in between those points. So a few years ago, we ended up with flash, or continuous glucose monitoring technology, which essentially is a little device that sits in the interstitial fluid, either of the arm or the belly, and it continuously monitors glucose in the background, so every 5 minutes or so. But the patient also has the ability to either take a reader or their smartphone and check their glucose whenever and wherever they want. So now they can get instant biofeedback on what a behavior has done to their glucose, what a medicine has done to their glucose. So we have all this data, but again, it was we sort of always have to pick populations first to start this technology in. And it was mostly in patients with type 1 diabetes who are on multiple daily injections of insulin, and where it's very important not to go low or hypoglycemic, but also to work on those hyperglycemic excursions. And so the data, really, the research has shown how effective it is in type 1 patients. So then the next population, it trickled down to were patients with type 2 diabetes on insulin. And again, the data is really robust that people on insulin who use this device do better in terms of blood sugar outcomes, less hypoglycemia, which is super important. And you're right, those over 65 who are on insulin will have this covered by the Ontario government, or someone who is working and has third-party benefits. Now, if we sort of think about who's left in that population, we have people without benefits who have no access to the Libre. So they may be working 2-3 jobs. They're busy. They might go low or have hypoglycemia, not really know, but they have no coverage. And I really believe that you don't have to be on insulin to get benefit from this device. And rather, if it's started early, it might prevent you from ever going on insulin or having to get to that point if you understand how your body reacts to high blood sugars.
Yeah. And as always, it's difficult to make that preventative argument to the people who are picking up the tab, because you need a much larger population over a longer period of time to show that you're actually probably saving money in the long run. And I think like the diabetes care landscape has changed significantly in the past decade with the newest oral medications that we have. So with SGLT2 inhibitors and GLP-1s, I mean, it's far less likely that somebody's actually going to end up on insulin, and hopefully they never have to end up on insulin, but they could very clearly benefit from having a device like this.
Totally. You got it.
Can you give an example in your practice of how using the CGM has been like a major change for patients? Like what have they realized that they didn't know before that resulted in behavior change?
Mm-hmm. So the classic diabetes education is food is medicine and activity is medicine. But if you have to wait 3 months for a lab test that shows you the fruits of your labor, it's hard to sometimes stay motivated. We get busy, there's the temptations around every corner. So having instant biofeedback is really a behavioral change game changer. And so if you get those quick rewards of, hey, I chose perhaps a lower carbohydrate meal, versus a higher carbohydrate meal, and you get that instant feedback of, hey, this really improved my blood sugars, that's a real positive motivator that can keep you going, for those 90 days until you get your A1C done. So for my patients, they've often been extremely surprised at their results. And I'll give you an example. I have 2 sisters who often come to the same appointment. They both have type 2 diabetes, similar risk profile, but one sister may eat a certain meal, and of course the other sister has the same meal, but their blood sugars are totally different. One can handle that meal and doesn't have big spikes, but the other one might have to cut down on the portions or make some changes or go for a walk after that meal. And so that's really eye-opening and reinforces the idea that in diabetes teaching historically, we know about the glycemic index and that certain foods are higher and lower in the glycemic index. And we know certain principles. Lower carbohydrate will often result in a better blood sugar, but we've never been able to drill down to the details and how it means individually. So kind of like that personalized medicine approach, which we're thinking about a lot. And there's so many variables that are different in person to person. Their degree of insulin insulin resistance, which is something we don't measure, yet, or really have an idea, or it really can change except for weight loss. But insulin resistance, the gut microbiome, there's so many evolving things that will determine different glycemic responses in someone on a similar glycemic food. So it's been really exciting for patients. And typically within the first week, there's some who, they are, gung ho and interested, but then there's also some who, like any technology, they start using it, but then it sort of drops off, or they're not able to make those links of, hey, what did I have for breakfast? That's why my blood sugar is higher at lunch. And that's where the Liberate program sort of puts the pieces together of matching, not just giving someone the technology that they might not have access to, but having a coach help them put the pieces together and learn from it. And and even though this is a 6-month trial that they're in the study for, I think it's information that they can carry with them for the rest of their lives. So my hypothesis is even that we might not need this expensive technology for the rest of your life if you're not on insulin, but perhaps at certain times, perhaps when you're on a new medicine or your weight changes or something happens, and you can use it to just tune into what's going on with your body.
Gotcha. So they get the device, and how often are they getting feedback from the coach? Like, I guess their data is probably going to be sent to a database that the coach can actually access and see what's happening in real time. So are they having weekly or bi-weekly check-ins?
Yeah, so we're into the O for the PICO now, the sort of the I mean the intervention. So the intervention is that participants, they'll first come and meet in person at baseline, 3 months and 6 months, and that's where we measure their fitness, their psychological behavior and feelings towards diabetes. And then we'll meet every 2 weeks virtually. So one of the nice things about the pandemic has really opened up virtual visits. So people don't necessarily have to take time off work. We meet virtually as a group, sort of 6 to 8 people in a group every 2 weeks, where we're then, we spend a small portion of the class, the 1-hour class, going through some information about diabetes. So perhaps learning more about the meter, how to really optimize the technology, how to get the most out of it, talking about food and activity as medicine. But then the majority of the hour is spent hearing about people's experiences and tying the pieces together. And the sensor, patients or participants are able to upload it to something called a Libre view, where we're able to see all of their data for 2 weeks. And we also give them a Fitbit to wear, and we can look at their exercise during those 2 weeks and see how it corresponds to their blood sugars. So we try to tie all that data together, talk about it, learn from it as the group. And we do that every 2 weeks for 3 months. And then at the 3-month mark, we sort of hypothesize that people have learned a lot, they're set, but instead of just cutting them loose cold turkey, we sort of will still meet once a month for a final 3 months. And then assess overall change. And if the Liberate program is helpful or useful in lowering people's A1C, that's sort of the primary outcome. We have other secondary outcomes as well. Again, then the hope is that we can package it all together and disperse it across Canada, because we know, a lot of diabetes education centers are really, the practitioners are skilled at food and glucose, but the technology piece is changing, is new, and often exercise is a topic that a lot of allied health professionals are not yet comfortable with. So we're providing them sort of a plug and play option.
So before I ask you, push you a little more on the exercise side of things. So for the study, have you enrolled people from London so far?
Yes, we started enrollment right before the holidays in December, and we have our first group up and running.
Okay.
Um, and we are in full recruitment mode. So if anyone is interested to learn more about the study, if they think they may be eligible, even if you're not sure, you can check out our website at www.liberateDiabetes.ca. You can also email us at liberate at lawsonresearch.com, or give us a call, at the clinic. So our number there is 519-646-6000, extension 67230.
Awesome. That's great. And I'll include that stuff in the show notes so people have links. So for exercise, so I think most physicians are kind of used to seeing the canned, yeah, well, you should do 150 minutes of moderate intensity exercise per week. And, I see that dictated in notes as I made this recommendation to the patient, but of course we know what happens. It never goes any further than that. There's no specifics. Exercise to one person means something totally different to another. For some, they picture themselves on a treadmill in a gym. For others, they're lifting weights. For others, just walking down the street. So how do you approach that in your practice with your patients?
So yes, this is one of my favorite topics, and I am so passionate about it because we're really able to affect lives and affect change. We've been able to get people off of medicine, get them to target. And folks that have significant challenges, so mental health, poverty. So it's often, we joke as physicians, the saying is, well, eat less, move more. But like you said, that's sort of an empty statement when there's not the right education, right support, and right behavior change support in place. So that's something I'm quite passionate in both clinical and research. Is, of course, people aren't going to do eat less, move more, because there's not a lot of helpful information in that. So I'm interested in figuring out how do we actually make that actionable, real life, and effective. So I think the bottom line is, typically, healthcare has been very prescriptive. Like you said, we know that 150 minutes of moderately intense aerobic exercise on most days of the week, plus 2 days of resistance training, is what we need, not just for our blood sugars, but for overall health. But a lot of my patients, that is a huge ask of them. They're sort of at the beginning phases of that journey, where we might simply need them to sit less or be less sedentary. So the Liberate approach is very different in that it's patient driven as opposed to prescriptive. So the easiest way to think about it is, this is sort of tongue in cheek, but I don't care how they bring their blood sugars down as long as they do it. And so now I'm giving the power back to the person to figure it out, using some tools that I've given them, but making it work for their own life. So instead of counting carbohydrates or being stuck to one eating plan, well, again, we're going to give them different suggestions and ideas of how to improve. But now, using the technology, they can experiment, they can play around. And in fact, in the Liberate program, we actively encourage that experimentation or playfulness. And try a smaller portion portion. Try mixing a fat with a carbohydrate. What does it do to your blood sugars? Let's talk about it. What did you learn? And sort of that self-experimentation again is more person specific and less prescriptive, and I think much more empowering when people can figure out what works for themselves and get that feedback, as opposed to what did my dietitian say? Can I not eat the cereal or not cereal? Like, people get very in their heads, and that's the worst thing that can happen, is when people overanalyze. They have decision fatigue, and then what do? You throw your hands up and say, I'm going to do nothing. I'm just going to, sort of do with what I'm comfortable with and what I'm used to. So we sort of build it sequentially, small changes, small habit changes, learn from them and incorporating them based, into their lives, as opposed to what thou must do. So.
Do,
So
do you do you have any?
if they don't get their 150 minutes, but choose food as medicine, and maybe only get 60 minutes, and their blood sugars are better, then we've won, right? So
Sure.
that's the approach.
But for exercise though, if somebody's interested, if they say that they've got the motivation to do it, like do you but they are sedentary already and or don't have any history when they were younger of doing any athletics or any kind of formal exercise program, like do you present a palette of options and go, well, you can walk, you can bike or treadmill, you can do body weight exercises, like because what I find in my practice is when you actually get to where the rubber hits the road and people are like, well, what do I do? The conversation kind of quickly gets into the weeds and becomes overly complicated. So like how do you navigate that?
So I have really struggled with this in the last decade of my career, in that as an exercise physiologist, I can craft the most complex, beautiful exercise program that will get you to achieve your goals. Absolutely. I know how to do that. But is that realistic and feasible in lives where we are working full-time jobs, sometimes 2 or 3 jobs? So I've shifted that perspective to just keeping it simple. So the number one place that we start with is most people know how to walk, right? So most people know how to walk, as long as they don't have a foot wound or a raging ulcer. It is, there's a few parameters where, exercise is not recommended, and we have to make sure someone is healthy before they start exercising. But simply standing less, so getting up every hour, doing 250 steps every hour. Again, and technology can be helpful to cue or trigger that. And then simply walking. So we start with, step counts as one way to prescribe exercise. So again, 8,000, 10,000 steps is the goal a day, but we figure out where is a person at. Maybe if they're 3,000 or below, then we know, okay, you're pretty sedentary. Let's aim for 3,500 steps the next week. And so we work on very smart goals, specific, measurable, attainable, realistic, and timely goals that are time measured. So the simplest is walking. Now, it sounds straightforward, but again, I've heard every single, challenge in the books out there. Well, we live in Canada. We're in January. It's freezing cold. What do I do? So we have to anticipate barriers and challenges, right? And that's where it often gets creative. But and the bottom line is really sort of scaling it back a bit and trying to figure out what's really important to a person, right? Is it, if they just want to make us happy and say, oh, sure, I'll exercise so that we're happy, they're happy, we leave the appointment well, but like, why are they motivated to exercise, right? What's the underlying reason? So we get quite deep into the psychology of health and wellness, and if there's resistance or a barrier, well, we chip away at it, every appointment we get. And I have the luxury of getting to see people over a long span of time. But I can tell you, there's a lot of bias too in healthcare for who things can be active. And in fact, I sort of joke that exercise is getting a bit of is having bad publicity in the medical world, in that there's a lot of physicians who are like, well, we tell people to exercise, they try it, they might not be successful, and now they're really down on themselves. They feel like they failed, they feel bad. So maybe we shouldn't even set them up for failure. Maybe we should stop talking about exercise. And I think that's swinging too far the other direction, because again, I think every little bit counts. I'm not looking for perfection. I am looking for often being mobile and less sedentary. And then we build on small successes. So a long-winded answer. I could talk about this all day, but it's a complex issue. And I think the other important piece is begging and borrowing your team and your support network. The studies, the diabetes guidelines put in their recommendation that supervised exercise programs do have better outcomes. But again, not everyone has access to a gym. We have, even in our clinic, we don't have the funding for a kinesiologist. We're still sort of waiting on the powers that be that can do that now. How I've cobbled it together is I have students from Western kinesiology students who do their placements in the clinic and offer patient support that way. And support is especially helpful if you're looking at resistance training, where if you've never done it, I do encourage people to get some guidance or some coaching on how to start, because it's a little harder to get it right than simply putting one foot in front of the other.
For sure, yeah. But I think that's also one of the mental barriers is, while I don't have access to a gym, it's like, that's okay. There's so much you can do just with your body, like just by walking, just getting outside, and all of the body weight resistance exercises that you can do. I mean, something as simple as doing air squats. But again, you bring up the technical piece, and it is important to get somebody who knows what they're looking at to give you some advice on whether or not you're doing the movements properly, so that you don't hurt yourself, so that you can keep doing it. But like you said, I mean, I think so much of it comes down to the behavior change piece.
Yeah.
So somebody has to want it before you're going to be successful. Otherwise, for sure, I think, people tell us a lot of things, or will, try to appease us, even though we don't need it. There's, the human dynamics part of it, for sure. Okay, so that's great. So if people may have the opportunity to be recruited to your study and get some of this stuff for free, that's amazing. Now I just want to shift gears a little bit and talk about the latest addition to the Diabetes Canada guidelines. So this is the type 2 diabetes remission chapter that was added. So you were one of the authors on that. I was kind of reading through it, and I think it's great that we now have definitions for what it means. And it's also excellent to get out there the fact that diabetes doesn't have to be forever. This is a disease that is reversible, and you will add years to your life, and good quality years to your life, by focusing on trying to reverse it or go into remission. And I think the definition for that was three months with your A1C below the diabetes threshold, off of medication. So that's the first major thing that I want to ask you about is some of these medications have dual, if not triple, purpose. So SGLT2 inhibitors are also used for chronic kidney disease, are also used for heart failure. So you may still have an indication for that, even though your A1C is now below the diabetic threshold. So how would you interpret somebody in that scenario? Would you say yes, you still meet the criteria for remission, despite still being on a technically diabetes medication.
So thank you for bringing up this guideline. It was a labor of love with an amazing team across Canada, and about 2 years, year and a half of work, and I was so excited to participate in this because, again, historically, the narrative has been that diabetes is a progressive disease. So at diagnosis of diabetes, your beta cell function, the cells that make insulin, are believed to be reduced, 30, 40, 50% at time of diagnosis. And then that curve of beta cell function just goes down over time, and eventually everyone will be on insulin. That's sort of what I was taught in medical school and residency. And so I'm I'm a bit of an optimist. I like to look on the bright side. And so I was in clinical practice, and I realized that patients, even on insulin, were able to get off their insulin and sometimes reduce their medicines if they had changes in their body weight, if they changed their insulin resistance threshold. And so it just didn't click with me, this narrative of progressive disease with people actually sort of changing their profile. So we finally have weighed into this topic from a Canadian perspective. So the Americans and the Europeans have already put out statements and guidelines on this topic, but there was a bunch of different definitions of what does diabetes remission look like, what are the criteria, and so we sat down sort of as a Canadian delegate and decided what is the definition, because first you have to have a definition in order to be able to achieve something. And then we looked at who is the best, who has the highest chance of remission, and then the nuances that you touched on. So technically, diabetes remission means that it's not a diabetes cure. Once you have diabetes, you are never cured from it, but you are able to lay it dormant. You're able to achieve control off of medicine with an A1C of less than 6%. Now, if you need medicines again, or your A1C goes up, then you've relapsed. So again, we're sort of using this technology that over time, someone may have multiple cycles of remission or relapse. Now, we also added in the Canadian guidelines that there's diabetes remission to pre-diabetes levels. So if that A1C sits between 6.4%, we consider that pre-diabetes. So if someone is off of medicine and with an A1C of that, they've achieved remission to pre-diabetes levels. If they've achieved those excellent A1C results, but they're still on medicine, then we've officially termed it as pharmacologically controlled diabetes. And it was a real quagmire, and it needed a lot of thought and thoughtfulness, because the concept of remission, while it can be very positive, can also be negative, in that, again, if someone has their heart set on achieving this definition of diabetes remission, but let's say they've had a heart attack, and so now they're on medicine that you mentioned, the SGLT2s, the GLP-1s, that confer cardiac benefits. So we've seen in the studies they reduce outcomes of death and future heart failure. So we kind of don't want them to be off those medicines, but they might feel worried or horrible that they haven't technically achieved remission. So we wanted to make it very clear in these guidelines that the goal is, to be off of medicine, but if you need medicine for cardiac, renal benefit, it's okay. And then perhaps, by shifting body weight, you're able to reduce your insulin or get off insulin, and that's a win. And we wrote an accompanying user's guide to the guideline that sort of goes into real world examples and cases of how to use these definitions and apply them practically in practice, and how not to, set up false hope and have someone, psychologically damaged by going through this process when it might not be that attainable. But again, I preface that by saying we should not hold bias, and have these discussions with our patients, because a lot of practitioners are surprised at who's able to do this, because we do often hold biases. But I'll leave it at that.
For sure. Yeah. And I guess you don't want to be seen in the patient's eyes as it's a failure if you don't meet remission criteria. I can think of many patients who I've had in my practice just got an A1C of 11% and it comes down to 7.5. And, that's a massive, massive improvement. And, simply because you're not below the, 6.5 diabetes thresholds, this is not a failure. This is a huge triumph of what you've been able to do. And then with the GLP-1 specifically, so this is, Ozempic, and everyone's heard of Ozempic now. It's, been in the mainstream media as everyone in Hollywood wants to get their hands on it for quick weight loss, and all sorts of indications that it's not approved for. But yeah, this is something that it's really too early to know how long somebody does need to be on it or if they can ever stop it. I actually have one instance in my own practice where a patient came off of it and regained like extraordinarily quickly, and all of their metabolic factors went off the rails, and that was a real wake-up call for me personally. I don't know if you've had similar experiences in your practice, but this is one of the cautionary tales that I have now for other providers, to say, look, you just need to really make sure that somebody is committed to being on this therapy indefinitely, as far as we know at this point.
Well, exactly. And, if we dive deeper into the guidelines, they sort of provide guidance on who may be a good candidate. And again, these are very evidence-based guidelines. So we came up with these criteria based on the current evidence. That doesn't mean that someone on insulin is not able to achieve remission, but the guidelines suggested someone early in their course of diabetes, so within the first 6 years, someone not on insulin, someone who's able to lose sort of 15 kilograms or 15% of their body weight. That's the person who may be able to achieve remission. But again, we sort of started our conversation with exercise, and we know that exercise does not help with weight loss in a ton. It can help with weight management, but in terms of actually losing weight, it's extremely hard to lose weight. And for diabetes improvement, it's often that weight loss that we need to affect insulin resistance and whatnot. That doesn't mean the exercise doesn't have 10 million other benefits on the body, but purely in terms of weight loss, it's a tough one, right?
It's hard to thread the needle on that conversation. Yeah. I've given that spiel to many of my patients now, and like it's really shocking for people to hear that, what do you mean? Like, just going for a run regularly now is not going to make me lose weight, or I've been frustrated because I've been doing this for so long now and I'm not losing weight. But it's just physiologically, metabolically, your body's metabolic rate will adapt to whatever you're asking it to do, and you will end up in basically a neutral calorie position, so that whatever you're doing for exercise, it's not going to give you that caloric deficit that you need to actually initiate the weight loss.
And so sometimes for certain patients, once we've sort of figured out who's the right match, medicine, we're at a really a renaissance time in terms of obesity management and weight management, in that we have medicines that appear not just safe, but seem to confer extra benefit, and they're quite effective at weight loss. And we'll be getting a new one in Canada later this year that has shown data to be close to bariatric surgery outcomes.
Is that the
So,
tirzepatide?
tirzepatide, exactly.
So
Yeah.
that, okay, so that's up for approval by
Yeah,
Health
it's been
Canada.
approved. It's been approved by Health Canada.
Okay.
So the word on the street is it's coming later this year to Canada. When exactly, we're not sure, but
Does that mean it's
so
gone through the CADTH review process and they've made a recommendation for reimbursement?
Um, I'm not sure where it sits with CADTH. I do know Health Canada approved it towards the end of 2022. And, in terms of the nitty gritty, in terms of coverage, TBD.
Yeah.
But again, the point is that we have medicines that can help people lose weight, not just for glycemic, but to help their arthritis and, of course, other conditions they might be struggling with. And when we stop those medicines, like you mentioned, the weight often comes back. So that would be a reason not to want to stop that medicine and go into technical full remission. Rather, maybe now they've been able to stop or lower their blood pressure medicine, because blood pressure is better with some weight loss, but they are on one medicine, their diabetes is well controlled. Well, for me, that's a win-win, and most patients will agree that's pretty awesome. But in terms of the long-term use of these medicines to maintain weight, there's research going on into that, and in the future we might see microdosing. So, do we have to be at the dose that helped someone lose weight? Or, do they need only a smaller amount to maintain that weight loss? That's where some of the research is ongoing, and that's for future discussions.
Yeah, that'll be interesting to know if you can start to just peel it back and
Yeah,
find,
yeah,
a
perfect
reasonable,
point. Yeah.
stable dose. Yeah. So I think some of the more interesting parts in the guidelines now is how do you actually go about inducing the remission? And I was a little, shocked to see some of the recommendations personally. Obviously, there's the bariatric surgery component, and I think that's covered like a whole other discussion for another time. But since we're focused more on diet and exercise at this point, so just the kind of take home in terms of inducing remission of type 2 diabetes with diet. And this is all based on RCT level evidence. So you have to use the evidence that's available, is to follow an 800 to 850 kilocalorie per day diet for 3 to 5 months, followed by a structured reintroduction of food and increasing that caloric amount. And obviously that will need to be done in a supervised fashion. So, that I get that in an RCT setting, because you've got resources, those meal replacements or supplements are often provided to the participants in those trials. I have trouble translating this to the real world setting to go, okay, now I've got a patient sitting across from me and we're going to talk about, maybe we can get you not diabetic anymore. And this is one of the possible routes to get there. You're going to go, so I'm going to eat how much for 3 months? Like it sounds maybe difficult to sustain. Like, so can you just give me your thoughts on that?
Yeah. So, to give you the backstory, We started with about 4,000 articles. We cast the net wide to look at what literature, what evidence is out there in terms of how did scientists achieve remission in their patients or their subjects. So from those 4,000 articles, we narrowed it down to like less than 10 articles that actually met our scientific criteria. So they were, properly created and executed, and they showed remissions, sustained remission at 1 year. At least 20% of the population had to still be in remission based on whatever protocol that scientist or researcher chose in their study. So in terms of what we call behavioral medicine, so food and activity, so not surgery, not technology, food and medicine, food and activity, it came down to, 3 or 4 trials that we based these guidelines on. There's the direct trial, the DIAM, U-turn, and the look ahead trial. So 3 or 4 trials that were really well done as of 2021. And those studies, so the U-turn trial, for example, put their patients on very low calorie diet. So not low carb, I'll sort of reinforce that it was a low calorie diet with the intention of losing weight. Again, that magic seems to be sort of around 15% of body weight or 15 kilograms of weight loss. And they achieved it by having people go on these very low calorie diets. So in Canada, our threshold is set at kind of 900 calories per day. We aren't really allowed to go below that. But you're absolutely right. How does a person tackle this if they want to follow this protocol? And then, other studies in those 3 or 4, they looked at sort of a mix of, low calorie with some exercise or some activity. And then the U-turn trial had more exercise. So they looked at 240 or 420 minutes of exercise a week with body weight loss of the 5 to 7%. So a little less weight loss, right? So the dietary intervention was a little less extreme, but they needed to exercise quite a bit more to achieve remission. So again, because we're evidence-based and we can't just, we didn't get to just sit around in a room and say, well, I had a patient who, was able to do it on much less, or, they definitely ate more than 900 calories. That's not a good guideline. But I'll tell you in a moment, sort of my own take and experience of that, of being in practice. That's exactly it. The final guidelines recommend very low calorie diet or higher intensity and duration of activity, all in that goal of weight loss and insulin resistance change. In terms of how to do this, part of your question, I'll give you the example that in London, we finally got a bariatric surgical program, but we don't have a medical weight loss program yet. So, so how does the average GP or, busy doc in the hospital prescribe a very low calorie diet? There's shakes, and we've heard about these soups, but what are they, and how do you prescribe them, and how expensive are them, right? So there's a gap between the evidence and real world implementation that we still have to work on to really, again, we want to set people up for success, right? So if they don't have access to a dietitian, it can be hard. If they don't have access to a healthcare provider who knows how to do a very low calorie diet, because they're effective, they really are.
But you want to make sure that you're still getting the appropriate macro and micronutrients
Right.
within that. So
Exactly.
when you're extremely
That's
limiting
right.
what you're eating compared to, the 3,000 calories you would typically eat,
Yeah.
then you need to be sure that it's meeting all of your other body's
So
requirements.
the guidelines, they recommend there's some certain commercial shakes and meal replacement programs that have been created to make sure all the macronutrients and vitamins and minerals are balanced, even within that low calorie consumption. So you wouldn't just want to eat, cucumbers to get your 900 calories a day,
Gonna be a
because
lot of
of
cucumbers.
you'd be very nutritionally deficient. So you'd want to do it right, but there's still a bit of a gap of helping people do that, at least here in London. Other centers, Windsor, for example, has a medical program. So that's one part of your question. And then I'll end with sort of my take on it, in that, again, I'm glad the conversation is starting, and that I've had a lot of colleagues say to me, oh, wow, it is possible to achieve remission. I kind of thought that was true, but I didn't know. So at least we're starting the conversation. Does it always have to be to that extreme in someone? I can anecdotally say absolutely not. Someone who has a diet that is very high in processed refined sugar and is very sedentary, sort of the extreme of the bell curve, they will have they'll be able to do not as much as drastically as that, to achieve really amazing results. So I've seen people go into remission without being on a liquid diet for 3 months. If that makes
Right.
sense.
Yeah. And I mean, personally, I've had patients who, once they gave up drinking like 2 liters of Coke a day, they became not diabetic anymore. Like it's incredible. Okay, and the exercise bit is interesting as well. So instead of the 150 minutes, so 2.5 hours a week, you're going to 4 to 7 hours a week, and I'm assuming that was mostly aerobic, like moderate intensity aerobic, so zone 2 type stuff. Is that
Mhm.
true? Or
Yeah, it was. It was actually they looked at aerobic and combined aerobic and resistance, and they used kind of going up to 10,000 steps a day as one of the goals. So again, achievable exercise options, but it's that time.
Mhm.
But if you're not interested in maybe cranking up your nutrition efforts, then the exercise is important. And if exercise isn't your jam, then your nutrition becomes really important, or you find a happy medium of both, and you get the benefits of both.
There's only so many levers that you can pull.
Yeah, exactly.
Um, do you, in your practice, do you use or chat with patients about intermittent fasting at all? So the reason I asked, there was actually just in December a couple of papers published, good RCTs, and one of them was they basically did a 5 days fasting, like air quotes fasting, followed by 10 days of ad libitum eating. And during the 5 days, they prescribed their diet, which was, I think it was I don't know, 600 or 700 calories those 5 days. But then the next 10, you were able to do whatever you were doing. So that over the course of time, you probably had a 25 to 30% overall reduction in calories, which resulted in diabetes remission for a significant portion of their group. So, interesting, and maybe a lot more of a palatable, no pun intended, intervention for patients than just doing that for 3 solid months. Do you use that as a strategy?
Mhm. So we, again, because we're doctors, we sort of think of, dosing. So what's the medicine? What's the dose? How do you take it? And are there side effects? And I think of diet prescription in or food prescription in much the same way. So I try to learn quite a bit about the patient first and figure out what their goals are, what their problems are. And for some people, it's, they're eating, they're grazing all day long, they're consuming a larger amount of calories because they may never have that satiety point, so they're never feeling full and they're just grazing all day long. While intermittent fasting really puts a kibosh on that grazing, right, in that you're only able to eat during a set amount of time, and as a result, for many of our patients, that results in a net caloric deficit. And that deficit then translates, hopefully and typically, in better blood sugars, less, sustained high glycemic, ups and downs, which gives the body a break. And there's lots of literature that, giving the body a break from constantly having to process food is a good thing as well. But it can also confer weight loss and then in turn improved glycemic control. So it's always that cycle, food and activity and obesity all come together. But for some of my patients, they hate intermittent fasting. They're grumpy, they're angry, they have blood sugars that actually rise in the morning because their liver is in panic mode, thinking this person is not giving me food. I'm going to generate and spit out glucose that I've stored in the liver. And so they become discouraged from intermittent fasting, because they're seeing their blood sugars rise the longer they fast, and that doesn't make sense, right? It's not for everyone, but again, it's figuring out what's right for the right medicine at the right time for the right person. But a lot of people do have success with that intermittent fasting approach.
I think what you're describing there is, yes, it has to be an individualized approach. There's just no way around it. And I think that's frustrating for a lot of people to hear, because they just want, okay, just what do I have to do? What's the healthiest diet? What are the supplements that I should take? Just what's the best form of exercise? And, people like us always try to make everybody crazy by going, well, it depends. Who
And
are
to
you?
tie
And let me ask some more questions. And anyway.
And to tie it back, to what we talked about earlier with Liberate and the Libre, is it goes back to, yes, do they want some people want a quick answer or a quick diet or a meal plan, and we shy away from that because that's not real life either, right? What happens when you forget your meal plan or you're out and about? Well, you've got a problem solve. So I think for long-term success and real outcomes and life-changing behavior change, we have to get our patients on board with brainstorming and problem solving, giving them the tools to set themselves up for success, but then also figuring out what's right for them, their body, their life, their circumstance. And that might change over time, right? Because this is the chronic disease. It's going to ebb and flow. You have the right support people in your corner to help you navigate. But I love it when my patients become super self-managers. That's sort of my definition of success or victory.
All right. Awesome. I think that's a good way to summarize and come full circle. I really appreciate you taking the time to share this with us. And like I said, I'll share all the links and whatnot in the show notes. So hopefully you can recruit some patients from this. And yeah, it was great having you on. Thanks a lot.
Great. And thank you for inviting me. And I know we could talk all day about this, but I think it's a really good place to start the conversation and we learn more. And I think the important thing is getting this word out to people and patients that there is hope. And diabetes, I always like to say, if it's well controlled, we do all this hard work to prevent complications, right? And the hard work hopefully leads to a healthy life and a long life. So thank you
Awesome.
very much.
Thanks, Sonja.
Bye.